Welcome to the medwireNews podcast. Following the recent publication of the updated EULAR guidelines for the management of lupus, we are speaking to lead author Antonis Fanouriakis. He outlines what's new in the latest guidelines and how they will influence clinical practice. First of all, Dr. Fanouriakis, could you tell me why there was a need for this guideline update?
There was a need to develop or to update the original 2008 recommendations in view and in light, of new data that have emerged regarding treatment strategies of the disease, new goals of treatment that have been validated by several groups, and also issues that have to do with therapy, for example, alternative regimens of glucocorticoid therapies, the use of, for example, of calcineurin inhibitors in lupus nephritis, in what is called a multi-targeted therapy, and also, of course, the approval within the last decade of the first biologic therapy for systemic lupus, belimumab. So we thought that there have been quite enough data over the past decade to justify an update of the EULAR recommendations for systemic lupus.
What's new in the updated guidelines?
If one would take it structurally, let's say, so this set of guidelines is much more, I would say, comprehensive in the way they are formatted and presented. So there's a section dealing with the goals of treatment. Then there is another section or heading, let's say, that deals with specific drugs, hydroxychloroquine, glucocorticoids, immunosuppressive drugs, and biologics. And most importantly, following that, we have a categorization of specific recommendations based on actually the organ system involved. And I think this is a major advance because lupus is a vastly heterogeneous disease, and what physicians frequently face as a problem is that they have generic guidelines that do not actually provide information on the specific organ system that prevails in each patient. So here now we provide specific recommendations for skin disease, neuropsychiatric disease, hematological disease, and renal disease. And we finish off with the last, let's say, category, which are the comorbidities, with a focus on infections and cardiovascular disease. This from a structural point of view. So now in terms of, let's say, practical recommendations, I would say that there are quite a few new data. For example, the recommended dose of hydroxychloroquine, which is considered the anchor drug of lupus, now is new, and the recommended dose is 5 milligrams per kilogram of body weight per day, of real weight. There's a recommendation for a more rational use of glucocorticoids. For example, now we recommend that treating physicians should aim for a chronic maintenance prednisone dose of below 7.5 milligrams per day by all means, and that this could be achieved either by the use of intravenous methylprednisolone pulses or with the early institution of immunosuppressive drugs. And then going back to what I was saying earlier, the new also is the fact that we provide specific drug recommendations for specific manifestations of the disease. And also we give pretty detailed, I would say, guidance as to when biologic drugs such as belimumab and rituximab should be used. I mean, in which case scenarios and circumstances.
So the latest guidelines are more comprehensive than their predecessors and provide more specific recommendations regarding drug use and treating different organ systems. Can you outline how you think they will impact clinical practice?
We hope that these sets of recommendations will actually give practical guidance to treating physicians, and that was our purpose, rather than being more theoretical or generic. Of course, guidelines can never capture all aspects of clinical practice and do not imply to substitute the judgment of experienced physicians, but their aim was more to try and provide them with some practical tips and guidance. We hope these guidelines will help, first of all, rationalize even more the way treating physicians, all of us, handle glucocorticoids, because for many, many years, disease has been, let's say, overwhelmed, and treatment of the disease has been overwhelmed by the use of glucocorticoids. So now we know very well, and we have data on that, the detrimental effects of glucocorticoids in the long term in patients. So what these guidelines actually aim is to push physicians towards trying, by all means, to minimize the exposure of patients to glucocorticoids in the long term. So by doing whatever they can in order to keep a chronic maintenance dose of maximum 7.5 milligrams prednisone per day. So that is one. And the other thing I would say is that we are maybe a little bit more cautious and careful regarding the daily dose of hydroxychloroquine, because now we have data with these new screening techniques suggesting that retinal toxicity from hydroxychloroquine may not be as rare as we thought in the past. So we're going to be a little bit more vigilant in our monitoring of retinal toxicity of hydroxychloroquine, and maybe actually lower the dose in patients that are in stable or a condition of low disease activity. And I think it will affect also my practice regarding the circumstances and the case scenarios that actually would justify the use of certain immunosuppressants. For example, we now have recommendations on how to treat skin disease, which agents to use when you have hematologic involvement, etc. And of course, the optimal and the patient profiles who would benefit more from the use of biologic drugs. For example, as an example, I would say that belimumab now is recommended in patients who fail or who do not respond to the standard of care, which includes hydroxychloroquine and glucocorticoids, but then with or without a prior immunosuppressive drug. So, in other words, it is not strict that a patient has to receive one immunosuppressive agent before being treated with belimumab in case he has a moderate or a refractory or flaring disease.
Did you encounter any particular challenges when developing these guidelines?
Actually, I would say the major challenge was the bulk of the work, the sheer bulk of the work, because it is interesting that the literature on systemic lupus erythematosus grows, I would say, in a geometric way. So there is a very big, I would say, increase in the material, in the available material that we had to review for the update of these recommendations. So it was a literature of 10 years, but discussing about tens of thousands of or thousands of papers that we had to review. And the other problem that I would say is that we still encounter a big challenge as to how, and regarding to the fact that we do not have very good data regarding especially extrarenal systemic lupus erythematosus. I mean, we do not have well-designed, randomized controlled trials that can guide us in order to provide solid recommendations in order to favor one drug over the other in cases of extrarenal disease. We have quite good data and high-quality data on lupus nephritis, but when it comes to disease that has only, let's say, involved other organ systems, then our guidelines and our available data are not so well justified and consolidated.
How do you think these gaps in knowledge should be addressed?
Now, this is something that has to do also with the research agenda in systemic lupus treatment and things that we have to discuss as a community. So what we need to do, I think, is that we need to try to design good clinical or optimal clinical trials and to try to optimize our study endpoints in order to, let's say, maximize the output of these trials. And for example, we would like more controlled or randomized trials that have either compare one immunosuppressive drug versus another. We had one such recent trial randomized comparing mycophenolate mofetil, for example, with azathioprine. So we would like to see more of these studies in the future. Another thing which would be interesting is that we would like to see outcomes of trials or endpoints that are both clinically meaningful and also maybe organ specific. For example, we have quite good endpoints or markers for skin disease that we have not actually seen them being used so much in clinical trials of lupus. So this would be interesting rather than giving, let's say, global indices or overall markers, just to maybe test the efficacy of different drugs in specific organ systems with validated response criteria in a way similar to the one that has been very successfully used in lupus nephritis. Of course, this is easy to say, but it's not so easy to do in clinical practice because not all organ systems are easy to monitor in the way that we monitor disease in the kidneys.
We've heard that the latest EULAR guidelines for the management of lupus should provide better guidance to physicians for treating the different organ systems affected by the disease. The guidelines recommend minimising glucocorticoid use and encourage vigilance when using hydroxychloroquine. Thank you very much to Dr. Fanouriakis for talking to us about these guidelines. You can read more about the recommendations in the paper published in the Annals of the Rheumatic Diseases in March 2019.